Hello and welcome back to the Rheumatology Physio podcast. Super excited on this podcast that we're on to the second of 5 in our AxSpA series, sponsored by Novartis. So thank you very much to them for helping us to create this series of podcasts all about axial spondyloarthritis. Hopefully you already went and listened to the first one, all about physiotherapy for axial spondyloarthritis. And this time we are talking all about AxSpA in primary care. So many questions do I get about blood testing, imaging, referrals, what to do with patients in primary care when AxSpA is suspected, and we get through all of it in this podcast. So once again, thank you very much to Novartis for supporting this particular project, and hopefully there will be a link in the show notes of the podcast or in YouTube or on my website to go and do a feedback survey. So if you wouldn't mind spending a minute or so, if you can find the link, clicking on that and just giving us a little bit of feedback, that would be super helpful. So for this show, I was delighted to be able to get Dr. Louise Warburton on the podcast. She is a GP with special interest in rheumatology and was ideally placed to talk to me all about rheumatology in primary care. We cover everything that you want to know if you're in primary care, and it is full of clinical tips and gold. And I think everybody will find this extremely useful. We give plenty of links actually in this podcast, which you may well wish to check out. So anything that's mentioned will be linked in the notes below, either the video or the podcast that you're listening to. So give it a click and you can go and find everything there, including the study days that Louise mentions. So make sure you go and see those. They seem like they're going to be brilliant. Finally, last plug from me, don't forget the Room 101 conference. It's at the end of April. In-person tickets in Manchester, virtual tickets as well. They're selling really fast. I suspect we're going to sell those out quite quickly. So if you haven't got one, go ahead and grab one. We've got 7 brilliant speakers and myself talking all about things rheumatology. It's going to be a really great morning and hopefully loads to be learned. Really excited. The speaker list is brilliant. I've confirmed all of the speakers now and I'm super excited. So if you want to find any information or book tickets, go to rheumatology.physio/event. So enjoy this podcast and hopefully learn loads about axial spondyloarthritis in primary care. Okay, hello everybody, welcome back to the Rheumatology Physio podcast. I am delighted to be joined by Dr. Louise Warburton this evening for a record. We're going to talk all about rheumatology, especially axial spondyloarthritis in primary care, which is something I have a little bit of experience on, but Dr. Warburton has a lot more experience on and a lot more information for us. We'll hopefully get into a lot of detail. So thank you for joining me, Louise.
Thank you.
So just to start us off, would you mind just introducing yourself to the listeners, what you've been up to in your career so far and your interest in rheumatology as well?
Okay, hi everyone. So I'm a GP. I trained and qualified as a GP in 1990. So it's a considerable time ago now. So I've had lots of experience. And for about the last, 25 years, I have been working in rheumatology. I started off doing a session in a local clinic in Shropshire once a week with a consultant. And then that morphed in 2006 into working in an interface musculoskeletal clinic. So that was about the time that the 18-week targets were launched. And my local CCG wanted someone to do a clinic to try and reduce the 18-week wait. So I started doing sessions in a musculoskeletal clinic just with one other extended scope physio, and the service has grown. So that's about 15 years ago, isn't it? It's now grown to be a massive service, really serving the whole of the east side of Shropshire. So that's Telford, with a single point of referral. So anyone with an MSK problem, that might be even just for physio, comes through our portal and the referrals triaged. And I work in the sort of rheumatology side of the pathway. We do have 2 consultant rheumatologists, but I would see anyone who's in that sort of grey area between, is this inflammatory or is it not? The people who are clearly looking inflammatory on the referral will go straight to a consultant. So I'm doing that now. Now, I was doing that virtually full time until recently. I've gone a bit more part time now. I'm also an honorary senior lecturer at the University of Kiel, so the primary care sciences research department. I'm a fellow of NICE, so I've been doing that for 12 months. And I've just been successful in getting a post as the Speciality Community Trust Research Lead for the West Midlands, because I work for a community trust and we've just started to become active in research. So I'm taking a lead role there. So that's my job in a nutshell.
Fantastic. I'm amazed you found 5 minutes to speak to me this evening. It sounds very busy.
Yeah.
So just to go on your department, because it sounds really interesting. So are the patients screened first before they come to you by a GP or someone similar, or is it self-referral?
No, it's not self-referral. It's a primary care referral. So they see someone in primary care. So that might be a GP or a first contact physio. So we have some FCPs in our service who also work out in the local practices. So there's a nice link there, and there's a lot of discussion goes on about patients. Should I refer this patient, etc. So they've all come from a GP or an FCP, but quite often during the pandemic they were all telephone assessments. So not many face-to-faces, which makes it harder for us.
Yeah, I can imagine. I can imagine. And what's the kind of how do I phrase it? The conversion rate, let's say, of your referrals in, and then we'll talk specifically about sort of rheumatology, but specifically to then a rheumatology onward referral.
There aren't many. About 2 or 3% go through to the rheumatologist.
Gosh.
We get 11,000 referrals a year. A lot of those are just for physio. Our orthopedic conversion rate, so the number actually going on to surgery who see an orthopedic surgeon, is about 80%. It's really good actually, because they get worked up. We'll do all the investigations, we'll try the treatments. So, but the although it's not much, 3%, is it? There's a huge backlog at the moment because of the pandemic.
And, for sure.
Yeah,
for sure. That sort of leads me on to the first real question, I suppose, which is specifically around challenges in primary care related to axial spondyloarthritis specifically. So have you got any ideas about any of those specific challenges really relating to those conditions?
Yes. So back pain's very common, isn't it? And 30% of GP consultations are about MSK issues. There's loads of people coming in with mechanical back pain, and unless you know what inflammatory back pain is and you can ask the right questions, it's really hard to pick up those cases. And because they present insidiously, you can't remember when it started. I think a lot get missed, and we know there's a big delay in the UK. It's 8.5 years is the current delay from first symptom to being diagnosed with an axial SpA. So that's one of the challenges. Another challenge is that in my area, GPs can request spinal MRIs, but the protocol that they can request is not the inflammatory back pain one. So there's a special protocol using stir images and T2 images, which look for bony edema, which GPs can't request. So they just, they might get an MRI back, doesn't include the SI joints either, which is reported as normal, and they totally miss the diagnosis then, and the patient believes the MRI is normal and they go away until they get another huge flare up or something else happens. So there's lots of challenges.
Yeah, for sure. I always thought when I worked in secondary care rheumatology, I got 40 minutes for an appointment as well.
Wow. Yeah.
And I always thought, imagine if I cut that down to 30 minutes, I'd probably be useless. And then, I see things with GPs working to 7 minutes or whatever it is. And I think, definitely difficult there, especially.
Yeah, but it's all in the history, really. I think if you can have time to take a good history and you listen to the patient, and you just get these, it's a sixth sense, really. Patients not telling you a mechanical story, that they've got fatigue, they're waking up in the night. You know, that your ears should prick up then, and that's the skill that you develop when you've been doing it for a few years.
Yeah, for sure. And I think what I've noticed as well is people who have been on my courses, they tend to have seen a patient, and then it's been worked up, and they've realized that patient has axial spondyloarthritis, and then they realize they don't know all of the information they need to know. How much do you think, I know there's been some research reasonably recently, so 2018 or so, when they canvass GPs for their knowledge of associated symptoms and inflammatory back pain. In your experience with those referrals coming in to your department, how much do you think is a lack of knowledge, or how much is pathway challenges because they don't have much time, or that MRI issue that you mentioned? Obviously, I assume it's a combination of the lot, but
yeah, it is really. And the people I've picked up have been the people with the less obvious histories. So it's, if you're a male and you're HLA-B27 positive, you tend to present it in your early 20s with more obvious features. But women, even the HLA-B27 positive women, don't have such obvious expression of the symptoms. And it may have just been grumbling on for years, and people think it's fibromyalgia. So those are the cases. I've picked up about 10 people like that in the last 2 years, you know, who might even be in their 50s by the time I've diagnosed them. So it's you know, I'm not blaming anybody at all. It's really hard to pick these things up.
Absolutely. And obviously we're sitting here with the specific interest in rheumatology as well, with certainly what I spend a lot of my time doing, and I don't do a lot else. And obviously GPs are doing all the other stuff as well. Even in your case, you're seeing other, like you said, orthopedics and so on and so forth. So it's, I think it's hard to, when they are those needle in a haystack of those back pains, and then you've got to get into the nuance of those symptoms. You've already talked about FCPs, first contact physios, a little bit. What's your experience so far with, obviously it sounds like you've had them in your department for quite a while, but they're obviously spreading out a lot more recently over the country. What's your experience of their ability in this sort of space?
Well, I've been training and mentoring the FCPs in my area, and I'm an accredited trainer. So I've signed somebody off for their part 1 on Monday, actually. So I think the FCPs in Shropshire have been indoctrinated, really. Certainly the ones around Telford, they all know all about axial spondyloarthritis. And I get lots of emails saying, oh, do you think this patient might have axial SpA? So as a group of clinicians, I mean, I think they're such hardworking, committed, dedicated people, because the pathway to become an FCP is just so hard. You know, signing off part 1 with all the different competencies that I was doing on Monday. I mean, it's like trying to do GP training, but in 1 year, you know, and we had 3 years to do it. So I've always been really impressed with the people I've worked with. I think they're getting a bit of a raw deal out there in primary care, because that they're not often getting the supervision that they should have, you know, the observed practice consultations that they need to sign off part 2. And there's some work going on in our area at the moment, trying to get that a bit more, working a bit more effectively.
Yeah, I can hear the pitter-patter of FCP feet off towards Telford as they listen to this.
I should say as well that the Primary Care Rheumatology and Musculoskeletal Society, of which I'm the education lead and a past president, we've done a lot of work in the last 2 years to support FCPs, and we've gained about 600 new FCP or APP members. So we do lots of training, and have you heard of the diploma, the FSCM PCRMM diploma? there's another one coming up in May. So we're running a couple of study days, March and April, 5th of March, 2nd of April. It's on our website. So that they are rheumatology training days, really, as well as some orthopedics.
Brilliant. I'll make sure we link to those for
thank you,
on the podcast. Yeah, so that people can. This will come out with enough time for people to be able to still book on those. So we'll definitely do that. I'm really glad that you're getting that kind of experience of the FCPs. I think I get a different bias because people ask me to go and teach them about rheumatology because they feel like they don't know so much about rheumatology, which is great. It gives me a slight concern that not everybody works for you. Not everybody's asked someone like myself to go and teach them, and there might be a little bit of gaps somewhere. But I know that a lot of the work around from Health Education England and things, I was involved in a little education program for FCPs as well. So I'm hopefully we're going up and up. What do you think about sort of the non-specialized GPs? Or generalist GPs sounds like a ridiculous phrase, but hopefully you know what I'm getting at. Are GPs on the same path to improvement, do you think, or do they need a little bit more cajoling?
Do you mean for rheumatology?
Yeah.
I think that the rheumatology training they get is often a bit lacking. And there was a study done some time ago now, about 20 years ago, asking GPs and GP trainees whether they felt their rheumatology training was any good. And they weren't particularly happy with it then, and they're not happy now. Some research done in Manchester shows it's very limited. Often just 2 days of dedicated rheumatology training. Where I was lucky in that my 3rd year medical attachment was on a rheumatology ward, and then I had a house job on a rheumatology ward. So I learned loads about it then. So we could do more, certainly, to educate GPs. And I'm working with the British Society for Rheumatology, who at the moment are keen to educate clinicians in primary care, whether that's GPs or FCPs. So watch that space. There hopefully will be some resources.
Excellent. No, that's really good. So let's go on and talk about some specifics within primary care. And I want to talk about investigations, really. So what I get a lot of specifically around primary care is, what do we order? What do we do with the information when it comes back? Should we order stuff? And I have a variety of different answers that I give, but I would love to get your answers. I want to start at bloods. We've alluded to MRI already, but I want to let's park that for a little bit. Let's start with bloods.
Okay.
So let's make the case simple. We've got a patient. They've got clearly inflammatory back pain. Let's say they've got a family history of AS, so it's pretty clearly obvious. So we're not worried about any red flags or anything else. What bloods are we ordering?
Well, you don't get any specific inflammatory rise usually in early spondyloarthritis, axial spondyloarthritis. So you're not going to get any diagnostic clues really, but it's always worth doing the baseline bloods, I think, because you can turn up all kinds of things. So you may find a normochromic normocytic anemia indicating chronic disease. You might find an iron deficiency because they've actually got Crohn's disease and that was undiagnosed. So it's just a good baseline. So you don't have to do that, but when I'm triaging referrals that come into the service, I would always check if the blood tests have been done. And I like to do a vitamin D as well, if you can get that done in your area. I know in primary care in our area that they're not very keen to do it. You've got to give a good reason. And the ones I request, I'm not kidding, 90% are low. So I know the argument is you might as well just treat them. But if it's very low, if it's below 15, or I think in our area it's 25 and they have to go on high dose replacement, you need to know about that, don't you? So the answer, we can't request HLA-B27 either in primary care. So I wouldn't bother doing that either. I would just refer to a rheumatologist or a clinic and expect them to do that.
Just to be specific, are ESR and CRP?
So again, I would request those, but I wouldn't expect them to be raised.
Yeah.
And I wouldn't sort of, put too much emphasis on the results, really.
Yeah, so that's certainly something that I see. So in my second opinion work that I get through, I'll get a lot of patients clearly inflammatory history, and then the bloods are normal.
Yeah.
And then people haven't been referred, or that it's been suggested it's something else. And so you're saying we should, order them if needed.
Yes.
But actually, if it comes back negative, you're not going to use that. It's going to be a little bit of clinical reasoning weight, I suppose, isn't it? But not as much as the subjective.
No. And with rheumatoid, then the nice guidelines say refer, don't wait for the blood test, refer. Don't be, if it's a negative rheumatoid factor, refer anyway if you've got strong clinical suspicion.
Yeah.
So don't wait for the blood tests.
Brilliant. Something I've become aware of recently is what's been phrased to me as an inflammatory blood screen. So apparently the way the bloods are ordered, they're on the computer, and you tick inflammatory blood screen, and it includes things like ANA, rheumatoid factor, and in my mind, I don't like that at all. It doesn't feel like it contains any reasoning process. But is that something that you've experienced? And if people have got that, what would you suggest that they do with it?
Well, the ANA is very problematic, isn't it? The anti-nuclear antibody. And the British Society for Rheumatology suggests that you don't request that unless you have specific features of a connective tissue disorder, because it can be positive in a low titer with all kinds of conditions. And there's a whole load of referrals come into rheumatology. Just please see this patient with a positive ANA of 1 in 80. They've got no features of joint disease or skin disease, and it just fills up the clinics. So I wouldn't tick ANA unless you've got a good reason to do that. Certainly the ESR and CRP are useful. I sometimes do a protein electrophoresis if the patient's got spinal pain and they're in middle age or older, because I'm worried about a myeloma. Again, I've picked up a few people like that. So I'm not sure what else would be in your inflammatory screen, but
my understanding is it's a selection that they sort of, it gets like I say, ANA, rheumatoid factor. Even someone told me there's an anti-CCP in there potentially.
So that's useful. But again, only if you've got features of a peripheral arthritis rather than a spinal one.
Yeah, for sure. So definitely order specifically for the condition that you're that you're investigating or you are suspicious of.
Yeah, and of course, when you're inexperienced, you don't know what to order, do you? And people tick all the boxes. But try and avoid doing that.
Absolutely. So, okay, let's go on to talk about imaging then. So we've talked about MRI, so let's start there. You mentioned that MRI with a stir into T2 weight protocol not available in primary care. So we saying MRI's no good for our axial SpA patients, or possible axial SpA patients?
Probably no good in primary care unless you can request that inflammatory back pain protocol MRI. I mean, you may be looking for other things. There may be a radiculopathy or possible disc prolapse or that type of history. That's fine to order the MRI, I think. But again, we all know that I think 20 people were invited in for an MRI off the street. They had no symptoms. 90% of the MRI showed an abnormality. So it's a very poor screening tool, really. You're going to pick up abnormalities, and then you don't know what to do with them, do you?
Well, that's one of my concerns is you pick up stuff that either gets blamed for the symptoms, do you know what I mean, or as you mentioned right at the beginning, it comes back completely normal and they get palmed off that way is problematic.
Yes.
Okay. X-rays is a big one. For me. X-rays seem to be fired off left, right, and centre. Give me your thoughts on X-rays for our query AxSpA patients.
Well, spinal X-rays are a huge dose of radiation, aren't they? So I don't request them for axial SPA. I know the NICE guidelines do suggest an X-ray of the sacroiliac joints, but I would leave that to the specialist rheumatologist to request if they feel it would help. So in our area in Telford, the only time you'll get a spinal X-ray is if you're suspecting a stress fracture or a vertebral fracture or some malignancy, perhaps. The request will be rejected otherwise. So it's not worth trying, and I think that's for good reasons, really.
Yeah. I'm glad radiology are rejecting. Even as 2 weeks ago, I saw a 20-year-old female who had a pelvis X-rayed.
Yes. What was that for then?
Query for possible AxSpA.
Right.
And then it obviously came back normal.
Yes.
And so they said, oh no, it's not that, because you haven't got any erosions in your SIJ.
So the erosions don't appear for ages, do they? So there's a time delay. Yeah,
for sure. So we're not really imaging. What about any use for diagnostic ultrasound? I know a lot of FCPs have got the ability to do that, or have a GP.
Yes.
If you've got a GP with especially special interest in sports and exercise medicine, something next door. Any utility in these patients for our ultrasounding?
Yeah, so I do ultrasound. I've done a rheumatology ultrasound course. I think the only time it would be any use is a peripheral arthritis, and people with enthesitis. So as part of the spondyloarthritis picture, you get dactylitis and enthesitis. I had a lady last week who, I think she was referred as a plantar fasciitis, and I wasn't suspecting spondyloarthritis, but then it was in both feet, and she complained of a painful heel, and I squeezed the bottom of her Achilles tendon, and she nearly left the bed. So she was really tender. So I straight away did a scan, and she'd got some enthesitis, some calcaneal erosion. So it's really useful then, because I would maybe not have referred her on to a rheumatologist, but now I've got evidence that she's got an enthesitis and does need to go on and be seen.
Yeah. And how about, so let's change the let's take your lady with the bilateral heel pain. So if I was sat in an FCP clinic, and no, I don't do ultrasound, and none of my GP colleagues have got ultrasound machine. Waiting list for rheumatology is quite long. Would you say, is that worthy of a referral to radiology to do the ultrasound rather than waiting through rheumatology? Or where would you sort of find that balance?
Well, first of all, I do an assessment and presents with bilateral plantar fasciitis. Is there a mechanical issue here? Is the patient really flat-footed or overpronating? And again, you'd be looking at the comorbidities. So has the patient got psoriasis? Does she have a family history of psoriasis? Has she got ulcerative colitis, Crohn's, ever had iritis, ever had a previous swollen joint? So the things that are in the spade tool, have you heard of that? SPADE. It's quite hard to find on the internet, because if you just type in spade, obviously you get loads of pictures of garden spades. But persist, you will find it.
Spadetool.co.uk.
Yes. So if she didn't have any of those comorbidities, I would just treat the plantar fasciitis first with insoles and exercises, show her what to do. And it depends on your waiting list, doesn't it? If she comes back and the feet are no better, and you've got a shorter waiting list in X-ray for an ultrasound, then refer there. I mean, in our area, there's a 6-month wait for a routine ultrasound in radiology. Wow, yeah. Whereas I can do one, and my colleague ESPs can do one, within a few weeks if it's urgent. It depends on your local area.
I suppose it's worth knowing what the waiting lists are for various, so you can make decisions like that, isn't it?
Yes.
Real. I really think, point of care ultrasound for me is something that I think is really super useful. Definitely. Like you say, especially with those peripheral presentations. We've just alluded to it a little bit there. I want to talk a little bit about pathways So rheumatology departments specifically, I mean, sounds like in your location, the pathway is easy. Just fire them to Dr. Warburton and all's good.
Yes.
But elsewhere, especially if people got to go directly to rheumatology, can you tell me much about the pathways that we should be selecting?
Yes. Yeah.
I know there's a lot of talk around, some people have asked me about spinal assessment clinics rather than rheumatology, or early arthritis clinics, those kinds of things.
Yes, yeah. So suspected spondyloarthritis would go to an early arthritis clinic, definitely. So if you've got one in your area, that's the place to go. And they triage the referrals. So if they're not happy, they will reject it. I would always, if you're suspecting axial spondyloarthritis, I would always go to rheumatology rather than spinal assessment. And the British Society for Rheumatology recently produced some referral guidelines for, people need to have these types of symptoms before they should be referred to rheumatology. And the Axial SPA ones are a bit based around the spade tool. So, and the NICE guidelines, and again, asking questions about psoriasis and other comorbidities. And if you've heard of the GIRFT program, Getting It Right First Time, there's a big push to stop anything non-rheumatological going into rheumatology clinics. So that's hard for us working in primary care, really, because if you've got a local rheumatology department who are going to reject anything that looks a bit in the grey area, it's where do you refer it then, to get a reasonably good opinion.
I've seen that, obviously, those referral criteria, and they're great, but my concern is like your patient you've just mentioned, where they don't fit a specific criteria, especially ladies who can present, they could have axial disease, but with widespread pain and peripheral symptoms, and they often don't quite meet the threshold, do they? And that's I definitely am a little concerned there when you have those grayer cases. And often I say to a lot of people working primary care, or certainly not in secondary care, it's those kinds of patients that are a real challenge, isn't it?
It is. And having discussed this with the BSR, yes, I discussed this with the BSR because I was worried about that as well. And they said you can always use advice and guidance to ask your local rheumatology clinic. But I think you just need to be need to have a good grasp of grammar and to be able to explain in your referral what you are worried about and what you're suspecting. So I get lots of referrals that are just one sentence, please see this patient with back pain. And fortunately, we get copied in the last 4 consultations. But even scrolling through them, sometimes you can't find any more information. So I would stress that people practice writing good referrals. Ask colleagues or GP colleagues, is this a good referral? Have I given enough information? And really, one thing to always say is, why are you referring the patient? So I am suspecting inflammatory arthritis would be a good opener, really, or I am trying to rule out spondyloarthritis for this patient. Then it's easy for the receiving party to know where to come from.
I'm definitely the other end of the spectrum, and I write 2-page referrals.
Okay.
Any feedback for me specific? Like, I write, everything. But I try to have a bit at the end. I do have a bit at the end. There's bullet points that say, like you just said, I'm referring for spondyloarthritis because X, Y, and Z.
Yes.
But do you see some of those as well, where information gets lost in the reams?
I do, and I would always put those bullet points at the top. So one of my ESP spinal colleagues does fantastic letters because they're very long, but she always puts at the top, her bullet points and what the management plan is. And I wish I could be more like her, really, because when in my GP letters back to GPs, I always try and do that, put the bullet points at the top, because as a receiving person, you may have 50 documents to read that day. So you just want the bullet points. So it's good to have all the information, and it, it gives me a message that you've bothered to take a good history and you've bothered to examine the patient. So it's more likely there's going to be something wrong.
Yeah, I like to include the spade tool as well, because I think it gives the
Yes.
recipient the idea
Yeah.
that you've asked the appropriate questions.
Yes, absolutely.
Because sometimes I'll see a letter and it will say that maybe they've asked about psoriasis, but then not, as you mentioned, they've not asked about Crohn's or colitis or iritis, for example.
Yes, yeah.
And then I'm immediately thinking, okay, I want to do this whole assessment again, because I'm not sure if they knew the detail to which I would want to know the answer to the question. What do you include the spade tool? Because you get a little graph, don't you? And it says recommended. Do you include any of that, or would you suggest including?
I think that's a good thing to do. Yes, definitely. And you know that some EMIS systems, so that would be great. And I know there is one FCP in Telford who does that, and they send me the spade tool. So yeah, that's really useful. So if you can do that, yes, please do.
AI is the way forwards, isn't it? It'll start collecting this patient's got a past history of psoriasis. Now they've got back pain, and it'll start pinging stuff upwards.
Yes, that's right.
Do half our work for us. Lovely. That's really, really awesome. Have you got any other sort of specific advice in primary care? So let's say someone's listening to us now, and they say, oh, I think I'm okay. I could recognize an obviously inflammatory back pain, but if it was a bit more nuanced or a little bit more of a grey area, I wouldn't know necessarily what to do. If you've got any advice specifically, obviously go to the PCR study days, but anything that we could give them pearls of wisdom now?
Well, I would always screen for fibromyalgia as well. So fibromyalgia often coexists with axial SpA, and you'd be asking then questions about poor sleep, coexisting mental health problems like anxiety, depression, previous abuse situations, and is the pain, they may have widespread pain which isn't in joints, but again that's quite difficult to differentiate from enthesitis pain. So the previous tender points for fibromyalgia, which have gone out of fashion now, are also areas where you get enthesitis in the body, so the lateral and medial epicondyle. So using those, I'm sure there were loads of people out there who'd actually got enthesitis and were diagnosed with fibromyalgia. So if you've got, it's like a seesaw really. If you've got most of the symptoms are on the fibromyalgia side, and not much on to give you a diagnosis of spondyloarthritis, then try and manage the fibromyalgia aspects first. To address the sleep problems, address the anxiety, depression. Maybe if you're an FCP, ask your GP colleagues to see them and prescribe something. And then if that's not helping, you may think it's more spondyloarthritis, they need a referral. So what I'm saying really is that you can manage some of these conditions a bit in primary care. You don't have to rush and refer all those grey cases. But if the weighting is more towards the spondyloarthritis side, and really I think it's the back pain, isn't it? So it's the inflammatory type of back pain. Is it better after resting, or is it worse after resting? And you could really drill down with a good history there. They need to see a rheumatologist. So if you don't have a local interface clinic, you're a bit stuck, really. I mean, you can, in Telford, you can refer anyone like that to us and we'll sort them out.
Wonderful. What about anti-inflammatories? Because a lot, again, obviously the GPs are prescribing. A lot of our FCP colleagues are prescribers. Is that something that you would say it's a good idea to do, don't do it, or somewhere in the middle?
Well, it's one of the diagnostic criteria, isn't it, for inflammatory back pain if they get a good response to nonsteroidals. So it is worth a try of a proper dose of naproxen. That seems to be the safest one. 250 milligrams 3 times a day with PPI cover. And if you've got a good going spondyloarthritis, there really is a very obvious response to that. and it happens very quickly in the first 24 hours. So if your patient's not really had much improvement, then stop them. I wouldn't keep the patient on them long term, because they all have side effects, don't they? Now, in rheumatology clinics, they often prescribe nonsteroidals, but they would use a COX-2, something like celecoxib, because that in the early stages of spondyloarthritis, axial spond, that is one of the first treatments, and it can be disease modifying and reduce some of the spinal bony changes. So I think the biggest issue there is GPs are not keen to prescribe long-term non-steroidals. They want to stop them after a few weeks, and your local pharmacist or prescribing advisor may be chasing you up as a GP, saying, why are you prescribing this drug for more than a few weeks?
Okay.
But if your rheumatologist suggesting it, then you should use it.
Yeah, for sure. I get occasionally the question of people saying, I don't want to because it'll affect bloods, or it'll affect MRIs, or it'll affect the reasoning, because the symptoms are different when they get to someone like yourself. Have you got any problem with that? Or
not with non-steroidals, but steroids certainly can do that. So if someone's had steroids and you're doing an ultrasound scan, then it really changes the appearances, and it damps down the inflammatory response. So I would not prescribe steroids in primary care unless you're absolutely desperate and you can't get a rheumatology opinion for 6 years or something. I mean, I always suggest that you try and speak to your local rheumatologist and say, this patient's really struggling, rather than prescribe the steroids. Can you see them quicker? So, but there is a bit of a tendency to just throw steroids at everything in primary care. So please try not to.
Anti-inflammatories are okay.
Yes.
Steroids not so much. Yeah. Okay.
No, only when you're sure that you know what you're treating.
Yes, I have seen a few patients. You mentioned epicondylitis, and I've seen a few patients who have had a few injections over time, and it's made their other joints feel better, and they almost go and have the injection because they feel better generally.
Yes.
Do you know what I mean? And that's not a good start, is it?
No, not really.
Wonderful. Well, I want to thank you very much for this conversation. It's been really, really enlightening, and really nailed on some of the information there for our colleagues. Just want to give you this opportunity to plug anything or promote anything that you're doing. Certainly PCR, MM. I never get the number of M's right in the PCR,
musculoskeletal medicine, MM. Yes. So yes, we're teaming up with the Faculty of Sports and Exercise Medicine to run the diploma, MSK diploma, for the second year. So last year about 500 people took that, and it's just a knowledge-based test. So there's no face-to-face examination techniques or anything. So it's considered a good sort of first step into specializing in the MSK field. So if you'd like to do that, go onto our website or the FSCM website and book yourself on. We're doing 2 study days as well to help people pass the exam. One on the 5th of March, that's a Saturday, and one on the 2nd of April, the Saturday. They're online. So again, it's easy to attend, really. They'll be recorded. So there's a lot of rheumatology in those. The other plug I should say is Versus Arthritis. So they have lots of really good learning resources on their website. And if you sign up as part, I think it's called the Professional Engagement Team, you can sign up there. You get all their newsletters, free access to all the resources. And they run core skills training sessions, which I do as well. Some of those are online, and hopefully they'll be back face-to-face soon. So most FCPs and physios don't need that training because they know all about examining the musculoskeletal system. But there's some rheumatology in there, which is useful.
Brilliant. And finally, Twitter. We've interacted a few times on Twitter, haven't we? What's your @ on there for people to find you?
At Loubicia, so LOOBICIA, which is quite hard to remember, but it's a nickname I had at school because there were 3 Louises in my class at school, so we had to have a different name.
Brilliant.
Yeah,
Absolutely
but
wonderful.
we've got primary care rheumatologists got a Twitter handle, our
Yes.
PCR Society.
Lovely.
So yeah, have a look at our Twitter feed there as well.
Brilliant, brilliant. Thank you very much for spending this bit of time with me. I think loads of people are going to find it extremely useful, and
good. And you're running a study day, aren't you, in Manchester?
Correct, I am.
Yes,
Yes,
yeah. A few of my FCPs are going on that. So
yeah, Room 101. Yeah, yeah. The best thing about that at the moment is the title. I just we came up with the name of a conference, and then we had to run the conference because the name was good. Yes, that's end of April. That is.
Yes, yeah. So yeah, good luck with that.
Thank you.
Yeah.